Welcome everyone to the final day of Creating Conference 2022. Today we are hosting 11 amazing speakers that again we are going to learn a lot from. And at the end of today we are having a session on common myth on creatine following with discussion with Dr. Kreider and Dr. Tarnopolsky and other speakers. So please prepare your questions again. But for now, let me welcome our first guest, who's Dr. Stephan Bakker from University of Groningen, the Netherlands. Welcome.
Thank you. Thank you for inviting me to this conference. And I would like to talk about my presentation, which I should be able to share now, but it's about my research of my group on creatine depletion in dialysis patients. And we published a review on it and a rationale for intradialytic creatine supplementation. It's about end-stage kidney disease, which is treated by dialysis. End-stage kidney disease is a leading cause of morbidity and mortality around the world. You must realize that in 2010, approximately 2.5 million people worldwide were treated by dialysis. And in 2030, it's projected that there will be 5 million people worldwide dependent on their life for dialysis. So it's a life-saving treatment, but it's very burdening because you have to be admitted to the hospital 3 times per week to undergo dialysis for 4 hours. It's associated with the poor quality of life and many health problems, which will be listed on the next slide. These health problems include sarcopenia, loss of muscle mass, severe fatigue, muscle weakness, depression, cognitive impairment, heart failure, and an increased susceptibility to infections and an adverse course of infections and multiple other problems. But this is just to give you an impression of the severe problems these patients are facing. Next slide. Causes of the health problems in the dialysis patients are, of course, exposure to repeated bouts of dialysis 3 times per week. They have to be treated 4 hours per 4 hours, and this is inducing inflammation and, of course, a loss of important nutrients because the dialysis machine cannot, like the kidney normally does, reabsorb nutrients from the ultrafiltrate, and so they are lost. I will come down to for creatine also later on. And there is no function or very poor function of the kidneys. It's well known, there are several well-known functions of the kidneys. These are removal of excess fluid because these patients have no or little urine production that has to be removed during dialysis. Removal of metabolic waste products, including urea and creatinine. These are removed by the kidney, but otherwise by the dialysis machine. And the kidney is producing erythropoietin, and that's the loss of this function induces low hemoglobin in these patients. And some less well-known functions of the kidney, they are never mentioned in textbooks or very fewly mentioned. Oh, I have to go back. Can I go back? That there is enzymatic synthesis of the kidney by the kidney. For instance, the activated form of vitamin D is generated in the kidney, and also guanidinoacetate. And that's an interesting thing with respect to creatine, because guanidinoacetate is the precursor of creatine, and this is synthesized by the enzyme aminoglycine, arginine glycine amidinotransferase in the kidney. It's also a little bit in the pancreas and a little bit in the brain, but it's mainly in the kidney. At least that was not in the literature, but we have found out that it is mainly in the kidney. I will show you in the next slides. This guanidinoacetate is then secreted by the kidney, comes in the circulation, and is converted by the liver to creatine. So it's in this enzyme is present in the kidneys, in the pancreas, in the brain, and this enzyme is not only making guanidinoacetate and later creatine, and which is converted to creatinine, but also homoarginine. And that's an interesting compound to look at because it's a metabolic end product and will not be converted anymore. So we use this to look in healthy kidney donors. So we used live kidney donation as a model for evaluation of the relevance of kidney mass for this enzyme function. So we used 127 healthy kidney donors and measured them before and after donation. You must realize if you donate a kidney, your kidney function will be halved more or less. It's not completely halved, but because there is compensatory growth of the kidney and hyperfiltration. So you actually, rather than removing half of the kidney function, you only remove 37% of the kidney. And in response, you see small water-soluble molecules like creatinine go up by 47% in this situation as an average. And whereas you would expect, if the kidney wouldn't play a role in the synthesis, you would expect other water-soluble metabolic compounds also to go up, but rather they, for homoarginine and guanidinoacetate, they go down, which is indicating that the kidney indeed plays a role in the synthesis of these compounds. And you can also see that the urinary homoarginine excretion is going down, actually reflecting that there is decreased synthesis of homoarginine. And you must realize that there is that for homoarginine, apparently it's less severe than for guanidinoacetate. So the endogenous capacity for creatine synthesis is severely affected in these healthy kidney donors. How will it then be for dialysis patients? That's a question later on, because they have no kidney function. First, we should realize that endogenous creatine synthesis is important for maintaining creatine homeostasis, because of the non-enzymatic conversion of 1.6 to 1.7% per day, the endogenous creatine pool is always losing part of its volume to creatinine, and creatinine cannot convert it back. It's excreted in the urine or removed by the dialysis machine. And from dietary intake, if you eat a normal non-vegetarian diet, you get approximately half of your creatine. You can ingest it from the food, but the other half has to be synthesized endogenously. And in the kidney, as I've shown you just before, that is the first step which is being made. It's importantly sitting in the kidney. So if you have no kidney function, you're not capable of endogenous synthesis, and your endogenous So we have started to evaluate that in dialysis patients, rather than using 24-hour urine collections, we have started to collect their dialysate, because the dialysate of patients who don't produce urine anymore is more or less their urine, and then you can see the endogenous synthesis of creatinine, for instance, from creatine in this dialysate. And we did this in approximately 55 patients to look at that. And you can see here some parameters before dialysis and after dialysis. You can, for instance, see that body weight is going down a little bit because they don't produce urine. So that has to be removed, the volume that they drank and the water that they generated during from metabolism during a dialysis session. And because it's only a 4 hour, there will be hemoconcentration. So you see the hemoglobin go up. And of course, the waste products like urea and creatinine, they are removed. They go down during dialysis. Albumin is also coming a little bit up because of the hemoconcentration. And we look then at the loss of creatine during dialysis. You can here see the creatine concentrations before dialysis and after dialysis. It's 26 micromole per liter, and after dialysis 21 micromole per liter. This is only small because the tissues release creatine to a certain extent, and it's buffering the circulatory concentration. But you must realize, despite the fact that they have no kidney function and that creatine is a small water-soluble molecule, due to which you would expect it to be high, it's very, very low in these chronic dialysis patients, because we have also measured it in the general population, the creatine level, and there it's approximately 50 to 70 micromole per liter, so more than 2 times higher than in these dialysis patients. So this is really reflecting creatine deficiency, probably at the tissue level, but for certain in the plasma. And here you can see the creatine concentrations again. So they are high and go down post-dialysis. This is the creatine loss during a dialysis. So it's 15.5 millimoles per day. So it's because it's reflecting more or less 2 days, and they have low muscle mass, 2.5 days. This is reflecting. So they have low endogenous creatine synthesis from creatinine synthesis from creatine because they have low muscle mass, of course. And this is, but they also lose creatine during the dialysis session. Normal people who would be creatine deficient, probably they would reabsorb it from the ultrafiltrate of the urine. But of course, the dialysis machine and the dialyzer are not capable of reabsorbing it, and so you lose it actually. So you have not only the conversion of creatine to creatinine and the loss to creatinine, whereby creatine is going down in the dialysis patients, but you have also actual loss of creatine during dialysis, and also of its precursors, guanidinous acetate and arginine. So, and if you then look at dialysis patients, so they have a low capacity of the enzyme AGAT because they have no functioning kidneys. It's more or less similar to genetic AGAT deficiencies. And these patients are born normally because they get creatine via the placenta, but after birth, if nothing is done, then they have no muscle mass and no brain development because of the low creatine synthesis. And later on, they started supplementing these children, at the age of approximately 1 year, but then they would have no normal brain development, and but they had muscles. And now they do prenatal screening, and they are treated with creatine from birth on, and they have normal brain development and normal muscle development. And we sometimes make the joke of the dialysis patient that it seems as if we dialyze the muscles out and the brains out, and it could actually be true, because they cannot endogenously synthesize creatine at an older age. I go to the next slide. Using the equipment with to collect the dialysate, we also have, of course, the capability of measuring creatinine excretion as a marker of endogenous creatine resource, because 1.6 to 1.7% per day is converted. The amount of creatinine appearing in the dialysate is a marker of muscle mass in these patients. And you can see that if we look at this marker of muscle mass, the patients with the lowest muscle mass have very poor survival. Only in the tertile with the lowest muscle mass, after 2 years of follow-up, only 40% of the patients was still alive. So this low muscle mass is really a problem in these patients, not only, of course, for mortality, but also for infectious diseases and their total behavior. And you can here see that it's independent, this creatinine appearance rate, of anything you can think of. If you adjust it, it remains associated with mortality. So it's a very important thing, a good endogenous creatine reserve. So we came to the hypothesis that with progression of CKD, losing of kidney function, creatine will become more and more an essential nutrient. And if you don't compensate the loss of creatine to creatinine, you will get fatigue, myalgias, loss of muscle mass, and impaired cognition, all things that are related to creatine in a certain, to an important degree. You have decreasing endogenous creatine production, so you will become increasingly dependent on dietary creatine. And the dialysis patients are the most severely affected people, because they also lose creatine to the dialysate. And then there is the trend in the general population for eating more and more plant-based foods, which of course don't contain creatinine, but it's also in the management of chronic kidney disease, because our patients have uremia and hyperphosphatemia and acidosis. There is a trend towards advising more and more plant-based foods, and of course there with the creatine deficiency trend will only increase. So we think we have a solid case for intradialytic creatine supplementation in dialysis patients, because the intradialytic creatine supplementation could prevent otherwise unopposed losses during dialysis, and they will replenish inevitable loss of creatine due to conversion to creatinine and excretion of that to the dialysate. So we will do a pilot study in 16 dialysis patients first, and we will have 4 groups, each 3 patients on treatment and 1 patient on placebo. We will do that for 6 weeks, followed by a 2 weeks washout, and the creatinine concentration in dialysate will be 0, of course, for the placebo, 0.5 millimoles per liter, 1.0, and so on. And the primary endpoint, you cannot see it here, it will be intra-erythrocyte creatine concentration, we will want to replenish intracellular pools. And this is an overview of the scheme that the pilot study will follow. And apart from intra-erythrocyte creatine pools, we will perform multiple other measurements, including measurement of muscle mass, of course, muscle function, cognitive function, overall performance, and we will have multiple questionnaires about well-being, health-related quality of life, and of course, on nutrition. And we are heading for a breakthrough there in dialysis treatment. Creatine is expected to result in a better quality of life in these patients, better independence in daily activities. They are now very dependent on their environment, usually, a better survival and less health problems in dialysis patients. And we do this with our collaborators from Creatinine and the UMCG, my own team. And the Creatinine people are people who have a company which has a patent for intradialytic creatine supplementation. And we work together and they fund the pilot study and later on the larger study that we want to perform based on the pilot study. That was my presentation. I'm open for questions now.